Right. Good morning, everyone. Hope everyone is doing fine. Just give me 1 second. I'm just quickly preparing the presentation and we will start in a couple of minutes.
Okay, perfect. Okay, guys, so we're not a lot of people today. We're literally just five. I do kind of like when sometimes we're just a small group. I'm sorry that I couldn't be there in person, but this is the best that I can do right now. Uh, so because we're so little, I mean, we're just a little amount of people, let's make this a bit more interactive. In a sense, if you have any questions or anything, feel free to just interrupt me. Tell me like, hey, like, just pop a question or something. Today, I'll be talking a lot about antibody therapies, but I want to be talking more about how we're looking at antibodies because how we look at antibodies, or sorry, how we looked at it, let's say 20, 30 years ago, is very different to how we look at them right now. So I'll quickly start sharing my screen. So out of curiosity, can you guys see my screen? Can someone let me know if they're
Yes, we can see it.
awesome? Thank you so much. Okay, guys. So today, I've actually called my presentation Antibodies and Beyond, purely not for the cheesy name or anything of that kind of sort, but purely because antibodies are much more than we really think about them. They're not these Y-shaped little proteins that are there to bind to stuff. No, can orchestrate any kind of an immune response that you would like them to have, actually. So before I really get into the small little, let's say, details about this whole course, I want to give you an introduction to, who is this person today in your screen giving you today's presentation. Well, my name is Firas Hamdan. I'm half Spanish, half Lebanese. I did basically my career. I started my career at the UK, University of Kent, where I did biomedical sciences. Kept doing a master's there, also in cancer. Did a second master's in infection and immunity, and where I managed to actually combine my master topics together, which was cancer, infection, and immunology, and where I did actually a PhD in cancer immunotherapies here at the University of Helsinki with Vincenzo Cerullo. I then went on to University of Maryland to basically keep to do this kind of small postdoc in COVID vaccinations, and now I'm back at the here with Vincenzo Cerullo, still working. But of course, throughout my time, I've done a lot of different types of internships. But one that really, let's say, stuck to me was this one. This was done in Netherlands during my master's in Utrecht. There, we were generating new types of antibodies against CD20, which is I guess most of you know it, the target for B-cell lymphoma. But the nice thing from this internship that was, let's say, unique and very like kind of caught my eye was purely that it was creating antibodies that were IgG1, but also IgA1 and A2. During that time in 2016, I never thought, generally all the antibodies in the clinic are IgG. Why is someone doing IgA? So that's something that intrigued me, and that actually made me push a lot of my research throughout my career to the point that I still use them quite often. And today I'll definitely be talking a lot about that research. But of course, another kind of joke, the kind of apps that might excite some people, it might be these. But of course, these are the antibodies that excite me. I'm very, very, very passionate when it comes to antibodies, and I'll guess today you'll get to see how. So today's lesson, it's going to be divided into two small parts. The first part is just general information regarding antibodies. This might be, let's say, quite boring for some of you because it's a recap about antibodies. But I think that by knowing a bit literally just the small little structure, the isotype, the functions of antibodies, it's just going to make your life so much easier to the second part, which I'm going to be talking a lot about antibodies in cancer therapy. And these could be basically monoclonals, checkpoints, antibody conjugates, and FC engineering. So the first person that ever, let's say, discovered antibodies was Paul Ulrich. We dub him as the father of immunology. He has, let's say, pioneered quite a lot of the discoveries in the current immunology field. he basically started to see these Y-shaped little proteins in our blood that he called them Kugel, which was probably, I butchered the name in German, but basically means magic bullets. And yeah, he was right. These were kind of magic bullets. These Y-shaped proteins were able to bind to specific epitopes, very specifically, hence the magic bullet. Later on, we started to find out more and more about them, and we found out that general structure is made of the following. We have an antibody is made of two heavy chains, which are connected to each other. Then you have two light chains. Each light chain is connected to the heavy chain through, again, a disulfide bridge. So this is basically what you have from the antibody. It's literally made of four chains, two different types. So the heavy chains, which basically the name comes from being heavier than the light chains. Then within the heavy and the light chains, you basically have two regions. You have the constant region and you have the variable region. This is one thing I love about biology. Names are quite self-explanatory sometimes. The constant region is constant, while the variable region is, keeps being variable. And it's the variable region that's found in the heavy and the light chain that is responsible for this magic bullet kind of properties. It's the one that is able to bind towards whatever epitope that might be. And most of these epitopes are coming from proteins, but sometimes they could be lipids and they could be also carbohydrates. Not so much, but it's mostly proteins, I would say. The constant regions, they're constant, but within an antibody isotype. I'll definitely go into that in a bit, what that does mean. But of course, when it comes to the antibody, one thing that we can do is we can break the antibody into basically these kind of parts. So when we add certain enzymes like papain that is found basically on ananas and pineapple, we can basically break this antibody in almost kind of like in half, where you have two Fab regions and an FC region. So these two regions, they're called Fab. They're literally made up of the variable regions from the heavy and the light chain, but also a bit of the constant regions from basically the heavy chain as well. But they contain all the variable regions. So the Fab, we call this basically fragment antigen binding because it's the fragment that has the antigen binding. So this Fab region is technically the region that's going to bind to whatever protein or carbohydrate or lipid that is basically destined to bind to. The lower part is called the FC. The FC is completely made up of the heavy chains. These are basically the constant domains of a heavy chain. This is basically called the fragment crystallizable. We called it this historically because this was the first part of the antibody that we managed to crystallize technically. But it's basically, at one point, people really disregarded the FC, never thought that it was really that important. But nowadays, we start to see that the FC is extremely important because the FC is able to actually orchestrate different types of immune responses. And today, we're going to talk about how we can tailor make an antibody to, let's say, orchestrate any type of antibody response or any immune response that we want. And it's all because of the FC. So as I was saying, technically, when it comes to the constant domains, when it comes to the light chains, you have two types. You have either the lambda or the kappa. They basically alternate, doesn't really matter. Both of them are literally the same. They don't have different functions. But when it comes to the constant domains of the heavy chains, that's where they differ. So you have 5 classes in human. You have IgM, D, G, E, and A. So by constant domain, we mean that if we basically take all the IgM antibodies, they all have the same constant domain. But of course, the constant domain between an IgM and an IgD is very different. And of course, this different constant domains that we have gives us different, let's say, classes of antibodies, which then give you different types of functions. Why do they differ? Well, first of all, it's purely because of one of the things is the structure. So for example, if we look at basically the IgG, you have this very small little hinge. This is basically called the hinge, which connects to the variable regions. With IgG, it's much smaller, for example, if you compare it to an IgD. IgE doesn't have that hinge. If you look at IgM, it's literally made of 5 different types of antibodies, basically together. IgA is double. So the structure already tells you that they'll have a different kind of function. They also have basically different places where they operate. So we'll definitely go into details in where each antibody operates. But one important thing is that these antibodies, they bind to certain receptors. The Fc binds to Fc receptors. What type of Fc receptor? Basically, it all depends on the constant domain. So we have IgG antibodies. IgG bind to Fc gamma. So we use basically the Greek alphabet in order to denote what kind of Fc receptor it's going to bind. So IgG binds to Fc gamma receptors. IgE binds to Fc epsilon. So again, we use the epsilon to denote the Greek letter for the IgE. And IgA, Fc alpha, IgM, Fc micro. So if you look at basically where the Fc basically gamma are, they're mostly found on, let's say, mostly neutrophils, more macrophages, and NK cells. If you look where Fc epsilon is, it's mostly found on mast cells and basophils. If you look at where Fc micro is, it's mostly on the B cells and macrophages. So because these antibodies are able to bind to different receptors, which are found in different types of immune cells, you have different immune cells being activated. So Fc epsilon only will basically kind of activate your mast cells and basophils. Well, mast cells and basophils, they have a very important job when it comes to allergies. Hence, IgE is a master, let's say, key regulator when it comes to allergies because of the receptors that it's binding to, the Fc epsilon, which are found on the mast cells and basophils, which are literally mediating the allergies. If you look at basically Fc gamma, they're mostly found on NK cells or macrophages, neutrophils, which are mostly found in your blood. So you can already start to say that this Fc alpha is basically this IgG antibody, is mostly going to be in the blood. So this is one of the reasons why every antibody has different functions. So we'll just go basically into small little details about each one of them. So I will start with IgA. IgA, you mostly find IgA in your mucosal sites because around your mucosal sites, you have a lot of Fc alpha receptors coming basically from the immune cells coming from there. So these are basically certain types of macrophages, certain types of dendritic cells. They have basically Fc alpha receptors. So IgA is mostly found in mucosal sites. These are basically through your intestinal or respiratory tracts. So think about IgA as a very, let's say, the first line of defense, because usually we are quite exposed to bacteria, but also viruses through our nasal compartments, through our respiratory or intestinal tracts. So having that IgA is going to help us a lot to neutralize a lot of pathogens. So their primary function is to really protect our epithelial borders that are at very big risks of being actually attacked. IgG antibody, it's the most important type of antibody when it comes to extracellular fluid. It's mostly found in your blood. So I think it's the highest amount of antibody found in your blood, the IgG. And the IgG antibody has a very crucial, let's say, function when it comes to protecting us from any kind of, let's say, microorganism in our blood. It's able to bind to them, it's able to neutralize them, but it's also able to clear it out through many different types of, let's say, immune effector functions. This could be basically taking our NK cells to kill them. This could be allowing our complement system to get activated and kill it off. This could be, for example, phagocytosis, which is basically immune cells eating this up. We'll definitely talk about this in a bit, but that's usually what the IgG antibody is good at. IgM antibody is quite a weird one because it's an antibody that's made of five IgMs all connected together through something called a J chain. So you have this J chain that connects these 5 IgM antibodies together. So it's quite nice and big. So the issue with these ones, these are low affinity, but you don't care because you're not really focusing on affinity right now. You're focusing on avidity. Basically, avidity is the sum of multiple bindings, because now you have 10 binding sites because every antibody has two, you have five. So now you're basically more focusing on the avidity rather than affinity in this kind of sense. But IgM antibody, its main, let's say, function is just activating your complement system. That's really what it does. And for those who don't know what the complement system is, it's just a proteins in our blood that once activated, they can destroy technically infected cells or they can infect bacteria as well. So they're just really good at doing that. But when it comes to IgM antibodies, our immune system only produces them just at the beginning of an infection. Because think about it as a net, because it's so big, it actually has this 5 different binding sites. It's beautiful when it comes to trapping, let's say, any sort of microorganism. But it's so big and it's so useless because it only can activate your complement system. It's not able to activate any different types of immune cells that you have around. It's very useless for that. So you only see it just at the beginning as like kind of a trap, but then basically our immune system starts to switch. They start to produce IgA or they start to produce IgG, depending where they are. If you have a microorganism in your mucosal sites, you produce IgA. If you have them in your blood, you produce IgG. So one thing that we use a lot with IgM, specifically in the clinic, is mostly maybe if anyone here has basically went to get tested for mono, so EBV, the Epstein-Barr virus, they always look at your IgM and IgG antibodies against the EBV. Why do they do that? Simply because if you have IgG positive, means that you have EBV basically infection. But if you're IgM negative, it means that it's not recent. If you are IgM positive, it means that it's acute, meaning that it's basically active and it's been quite recent. So we use IgM quite a lot in the clinics to tell us a lot, about is this infection quite new, or is it has happened a bit further down the line? And then we have IgE antibodies. IgE antibodies are a bit weird. They are basically antibodies that are produced internally in response to a allergen. So what happens is that the first time we actually, let's say, we are exposed to pollen, the first time we're exposed to pollen, we do not develop any symptoms. But what we do develop are IgE antibodies that bind to pollen. They bind to these Fc epsilon receptors, which are found in your basically mast cells and basophils that I was talking about. They bind to them, and that's it. This interaction is of a very high affinity that usually, very rarely do you see them basically separating. They just stick there like there's no tomorrow. Then your second exposure to pollen, what happens is that basically a pollen molecule is going to cross-link, so it's going to bind to two of these IgE antibodies that are bound to your Fc epsilon receptors, and that's going to cause the activation of your mast cell or your basophils. And they're going to really start releasing a lot of different types of chemicals that make us sneeze, make us basically give us this red, this itchiness, all these symptoms related to allergies. Of course, IgE antibodies also have a very, let's say, we used to think that they had a very important role when it came to protecting us against platyhelminths infections. These are basically fungal infections and that sort. But honestly, not really. When we basically got mice and we removed their IgE antibodies, they really were not, or even human beings that didn't have IgE antibodies, they were not, let's say, susceptible to platyhelminths diseases or infections. So we started to think like, hey, would it be a better idea to remove just IgE antibodies from our system? Because what are they used other than for allergies and making our lives a pain in the ass? IgD antibodies has always been a mystery. It's only until like just recently we started to realize a bit much more what they do. They are actually much more related when it comes to the protection phase. Sorry, not the protection, the activation phase, so more B cell activation. They are needed to help a B cell, which are the ones that are producing antibodies, to create antibodies. They help them to mature enough. So without an IgD, we don't have a lot of antibody production. So it's much more needed for B cell activation and more B cell, let's say, maturation to produce antibodies. So one thing that basically we start off as basically I just said, we have our B cell. So the B cell is, first of all, let's say you have a naive B cell, naive meaning that it's not exposed to any sort of microorganism. Once it actually is exposed to a certain microbe, it's going to get activated, and then it's literally going to start, producing many different types of cells. But more specifically, it's going to create a plasma cell. So the B cell creates a plasma cell. This plasma cell now is literally responsible for production of antibodies. And usually the first antibody that the plasma cell will produce are IgM. As we said at the beginning, it's a net. Think about it as it's releasing a net to trap and neutralize any microbe or pathogen that you're basically being infected with. Then, depending where basically the infection is, you start to basically have either a class switching. Either IgM goes to an IgG, to an IgA, or IgE. Again, it depends. If you're basically the microbe is in the blood, then the plasma cell is going to switch to an IgG. If it's in the mucosal respiratory tract, IgA. If it's an allergen, then you're going to get it an IgE. So basically, you start creating these different types of antibodies. But what also happens, of course, during here, so this is the microbe, you take over here. Other than, of course, your FC being changed, we also need to make sure that our antibodies are binding very well to the microbe. And that now comes to the variable regions. The variable regions, they're literally consisting of two different types of segments. They're consisting of the hypervariable regions and framework regions. So the variable region, basically the framework regions, there are four of them. They're called FR1, 2, 3, and 4. These are more there to kind of give support. They're just there as scaffold. So that's why they're called framework regions. Then within the variable region, you have three hypervariable regions. So we call them basically HV1, HV2, and HV3. The name is, again, self-explanatory. They're the ones that are very variable. They keep changing. And these are the ones that are literally binding to whatever, epitope or what protein that there is in a microbe that we're trying to target. These hypervariable regions, they have CDRs, basically. They're called complementary determining regions. So basically the variable regions, they have the CDRs. So these are the regions that determine what they're going to bind to. So that's what technically it is. So this is basically, if we take the heavy chain region, this is the variable region of heavy chain. This is what it looks like. You have basically these four. So HV1, so this is HV1, sorry. This is the framework 1, 2, 3, and 4. This is the hypervariable region 1, 2, and 3. So if you look at the variability, the frameworks are not that variable, very little. But if you look at basically the hypervariable regions, the variability is quite a lot. It's almost 100%. It's basically 100%. This is quite how high it can actually get into. And the same thing we go when we see the light chain variable region. You see these four frameworks and three hypervariable regions. And the hypervariable regions, they contain the CDRs, the complementary determined regions. And this is basically what determines what the antibody is going to bind to at the end. And of course, this is just another example of different antibodies where you see the CDRs, the hypervariable regions being very different. So what happens basically now that you have an antibody, now you've created an antibody that's able to bind specifically to wherever you want it to be. This, let's say, binding of, let's say, antibody towards, antigen, it can happen through only CDRs. And this is this very, let's say, nice and perfect kind of binding. But also sometimes you have the frameworks coming together to help it. Not really, it doesn't really bind, but it kind of helps a bit your complementary determined regions to further push. So this is why if you go back over here, we do see a bit of variability, but this variability is kind of mostly surrounding your hypervariable regions, because the frameworks can also be helping it. But anyway, when it comes to the binding of an antibody and an antigen, the most important thing you need to remember that it's non-covalent. It's actually a sum of many different forces, specifically electrostatic, hydrogen, van der Waals, and hydrophobic forces. These are the ones that are making the antibody bind to your antigen. And in that kind of sense, basically, what I'm trying to say is that the antibody and epitope is not permanent. So this complex of an antigen antibody will at some point break. And that's very important. So how do actually, let's say, now that we have an antibody that binds to a pathogen, how it's able to eliminate it? Well, three ways: through neutralization, opsonization, and the complement activation. I'll definitely go into more details of each one. So neutralization, this is extremely important, specifically when it comes to, let's say, bacteria that secrete exotoxins. Let's give an example. We have, for example, Clostridium tetani. This is a very important bacteria that releases literally this tetanus toxin. And we know that tetanus toxin can really inhibit a lot of neuron action and really can lead to a lot of basically chronic muscle contractions, which is quite painful. So what our immune system can do is develop, let's say, antibodies, specifically mostly, let's say, IgG, that are able to, let's say, neutralize, that are bind to the tetanus before that toxin is able to interact with a certain receptor in our host cells. So it's preventing damage to your host cell per se. So these are all different types of literally bacteria that can cause us so many different types of diseases because of the release of toxins that they have. And because of our antibodies, they're able to neutralize them. And then you have opsonization. So opsonization, what that means, it literally, think about it as flagging. So you're literally taking a microbe or any kind of pathogen, and you're literally flagging it. You're flagging it for your immune system to come in and eat it. So it's super important. So, for example, let's imagine this is your bacteria. Now you're opsonizing it, so your antibodies are literally flagging it. And what happens is now your macrophage, through its Fc receptors, it's going to be able to bind to it and able to basically to eat it up. Because if you think about macrophages and a bacteria, let's imagine you have a macrophage here and a bacteria that is basically naked. Nothing around, nothing surrounding it. No antibodies, nothing. The macrophage will have, let's say, a 5% chance of eating it. If the bacteria is now covered in an antibody, from 5%, you jump off now to almost 90. So that's what opsonization does. It really helps a lot certain, let's say, pathogens to be, let's say, recognized. So, and in this kind of case, you actually have phagocytosis. This can happen through a macrophage, but it can also happen through a neutrophil. So it always happens through the Fc from the antibody and the Fc receptor. It's this interaction that mediates this phagocytosis. This could also be from the mast cells, as we know. Basically, this opsonization. So when you have the allergens, they're literally causing this degranulation when it comes to a mast cell. Another one that can also happen is your complement activation. So I'm not going to go very into details about the complement activation, but what technically happens is, let's imagine over here, you have basically this bacteria where you have this, let's say, IgM antibody. It binds. You have this C1q antibody. Sorry, no, it's C1q molecule. And C1q molecule, what it really does, it just activates a series of proteins to cut each other and insert this huge, literally barrel-like, kind of this whole barrel on top of a bacteria or infected or cancer cell, and it's just going to make the cell completely blast. So the complement system, I'm not going to go very details into this because that is a whole lecture by itself, but just to know that antibodies can actually activate a certain arm of our immune system that's called the complement that can really actually kill bacteria, viruses, and also infected or cancer cells. So now this comes to basically our second part, which is therapeutic antibodies. But before moving on, do you guys have any questions? Anything that you guys want me to go quickly over?
I was thinking about the IgA antibodies,
Yes.
since if they're dimeric, is that process also reversible, that they can like unbound from together, or are they always dimeric?
Oh, that's a very good question, Erin. Well, nice to see you as well again. Uh, so when it comes to IgA, this is when you go a bit more deeper into the different types of antibodies. They can be dimeric and they can stay dimeric, but it's not the only IgA. You can actually have you have the dimeric form, which is just double, but then you also have an IgA1 and IgA2, different subtypes of these antibodies, and those are monomers. So there's different types of antibodies, and even within IgG, there's literally 4 different types of IgG as well, which are a bit different, which we might be speaking a bit about. But the dimeric form of an IgA, it stays like that. It's not reversible. It's literally connected through the J chain, unless you have a certain proteolytic enzyme that cuts the J chain. Then it's gonna be unbound. But in generally, it stays like that.
Okay, that makes sense. Thank you.
Thank you. If there's no questions or anything, let's go now to the fun part. So now it's more about how. Now we know a bit about antibodies and all that and all those sorts. How can we use them for combating cancer, combating infections, or different types of diseases? Well, before we let's see start saying how can we actually use them, how can we develop them? Well, the most, let's say, common way of developing a antibody is quite simple. You take a mouse, you inject it with whatever, let's say, epitope you want. Let's imagine I am here and I want to create an antibody against influenza. Okay, perfect. What I do as I get the influenza, I inject it in this mouse, and then I isolate its B cells, because we know the B cells are literally creating these antibodies. What I also do, meanwhile, I culture cells, and specifically myeloma cells. Myeloma cells are literally cancerous B cells. So basically I fuse them together to create a hybridoma. Why would I ever think of doing that? Well, quite simple. These B cells that I took from a mouse, they are not, when you culture them, give it a couple of weeks, they die. They're not immortal. When I fuse it now with this myeloma cell, now these guys are immortal. And these guys will produce so much more, because cancer cells, they are A, immortal, but B, have a default setting of producing so much proteins that their machinery for producing it is at high rank. So when you add them together, these hybridomas are now literally these giant factories of antibodies. And the thing about that's very annoying in this kind of process is that when you actually isolate B cells from this mouse, so you can see these B cells, they have different, let's say, colors. So this is yellow, red, purple, and basically, I think there's more like kind of this lighter version of purple. So different colors. Why are they different colors? Because they signify that this will produce a different antibody that binds to influenza. Same thing. They all produce antibodies against influenza, but they all basically have antibodies that bind to different parts or have different affinities. So it's a polyclonal response. You have so many different types of B cells producing all antibodies against influenza, but some will bind very, let's say, at high affinity, some at low affinity, and some will be binding at parts that you don't want them to be bound to. So from this, I remember when I was doing this in my master's, I was creating something like, we're talking about almost 700 different types of hybridomas. So 700 different types of hybridomas that are producing all, they're all producing antibodies, all against CD20, which was my target, but different affinities. And at the end of the day, I'm not going to be basically characterizing 700 antibodies. That's impossible. So at one point, what I had to do is screen. So what you do is you take your 96-well plate, you put hybridomas literally, and one hybridoma per well, and then you put basically your antigen that you want to screen against. And then you start seeing which one is able to bind very well. So in generally, if let's imagine that you have, let's say, this is influenza, this would be, let's say, the specific protein in influenza that you want your antibodies to bind to. This was, let's say, back in the day, they used to use slaves, aka basically my students like me, to do this process. Nowadays, things have been developed a bit more. Now we have automated machines to do this, thank God, because it was such a pain. I remember when I was doing this, I started this whole process literally very early on in the morning, and I think I finished around 4 or 5 in the morning with the whole screening. So it's a very lengthy process, but now thankfully to automated machines, this can be go quite smoothly and easily. But now you've created, perfect. Now you have your antibody. Let's imagine you selected this one over here in yellow. This antibody now is against basically the influenza. But the issue now is that this antibody is coming from a mouse. So you've created a mouse antibody. If I go now and I take this mouse antibody and I inject it to a human, we create something called HAMA response. It's literally human anti-mouse antibody response. So where our own antibodies are actually binding towards the mouse antibody. Because what happens when you inject a mouse antibody to a human, the mouse antibody, and specifically the constant domains and all these other domains, they're foreign to us. We've never seen them before. We do not have mouse domains or all this kind of stuff. So our immune system is gonna freak out and it's gonna create an immune response against it. Hence this human anti-mouse antibody response. So you have, of course, when you actually have this response, our antibodies are binding to the mouse antibodies and they're clearing them out. So they're not really doing much of any sort of efficacy. You have very poor tumor penetration. These mouse antibodies do not penetrate a lot the tumors. Let's imagine you want to create an antibody against the tumor. They're not really going to penetrate. You start creating a lot of hypersensitivity reactions. Because our antibodies are not binding to the mouse antibodies, this can actually activate our immune response and sometimes can overactivate it to create hypersensitivity reactions. This could be basically like itches. This could be literally kind of making our blood vessels leak. This could be so causing edema. This could be technically, let's see, redness and sort of, let's say, kind of these skin ulcerations, which is quite nasty. So when it comes to human anti-mouse antibodies, you can only use them for acute interventions. I think the only acute intervention that you technically use them for are transplant. So I think the only antibody, let's say mouse antibody in the clinic, is against interleukin-2, which is interleukin-2 is needed for your T-cell responses. And T-cell responses are the ones that are causing basically your, let's say, your transplanted organs to basically be rejected. So you use anti-interleukin-2 that are coming from mouse just for the acute to kind of prevent it from prevent your T cells from killing your organs. But that's the only mouse antibody in the clinic. So okay, now we create the mouse antibody. What can we do from this mouse antibody to make it less immunogenic, meaning less basically, you know, let's say make it more human, make it in a way that when we inject it to a human being, we're not going to create this HAMA response. Well, there's basically two things that we can do technically from this mouse antibody. We can chimerize it. What that basically means is you take just the variable region from the heavy chain and the light chain. So you take the variable regions and you put them in an antibody that is fully human from the constant domains. Because we know the sequences of a constant domain, because again, they're constant. We know them. So if you want an IgG antibody, we just take basically the constant domains of the heavy chain and the constant domains basically of the light chain. And we just take these variable regions that we just created from the mouse and we just put it inside here. This is called chimerization. This now creates less HAMA responses compared to mouse, because of course the majority of it is human, but you still create HAMA responses because there's certain frameworks that are seen as, let's say, foreign to our body that's going to create still an antibody response. So what we can do still is literally humanize it. This is much more specific. So what you do from these variable regions, you only take the CDRs, the hypervariable regions, only those, and you add them, because we know the frameworks. The variability of the frameworks are very little. So we only take just the hyperavailable regions, and that's it. This is called humanized. So again, you're minimizing still the amount of HAMA responses, because now you can see it's just getting more and more human. But you still sadly create some sort of responses, some HAMA responses, very little, but you still do. So now the new type of antibodies that are coming in are fully human. Everything is human. How to do that? Oh yeah, by the way, one thing that I forgot to say is that every time you look at an antibody in the clinic, look at the suffix at the end of it. If it's OMAB, it's a burin. If it's CMAB, it's chimeric. If it's ZUMAB, trastuzumab, it's humanized. If it's UMAB, atezolizumab, for example, it's fully human. So by looking at their suffix, we can actually determine what antibody it is. Like what kind of antibody. Is it chimeric? Is it humanized? Is it fully human? But how do we create fully human antibodies? Well, what you can technically do is you basically do this, it's called phage display. So you take phages, and what the phages are, these are small little basically viruses that basically infect bacteria. But what you can do with these phages is you can basically make them express anything you want in their surface. So what you can do is you can create a huge library of phages that have literally CDRs, or basically variable regions of all human antibodies that you know. So you basically create, let's say, a library of 1 million phages expressing 1 million different types of variable regions from human antibodies that you know. And then what you do is basically, in this case over here, you basically have, let's say, your antigen, you fish out whatever phage is able to bind to it. And then you know what human antibody can bind to it, and that's it. The issue with this one is that you're limited by your library. So it all depends on how big your library is, because of course you have 1 million let's say 1 million antibodies that you know, you're bound to that 1 million. So you have a certain limitations. The golden standard, let's say the best way to do this, is getting a mouse and removing its locus. So the area where all the genes that are producing your antibodies, remove it and replace it with human genes that are producing human antibodies. So literally now this mouse is transgenic, because now it has a locus that is filled with human genes that are producing human antibodies. Because now what happens is that when you repeat again the same, let's say this over here, immunization, now these antibodies, these B cells are creating human antibodies because they only have human genes to do so. So now you have now almost kind of an infinite, let's say, amount of antibodies being produced, rather than, let's say, for example, here in this case, 1 million. This is extremely expensive. This is like, I don't think I've seen ever a group that is that rich to have these mice. These are very expensive to have. Usually it's mostly pharma or, let's say, very wealthy biotech companies that are able to, let's say, take these mice. So they're quite, let's say, special in this kind of sense. Okay, now that we've created our antibody, let's imagine now our goal is to create an antibody to, kill cancer. How can an antibody destroy a cancer cell? Well, 4 ways. It can block, it can signal, or it can actually induce your immune responses to kill it, either through antibody-dependent cell-mediated cytotoxicity, which basically means it's cell-mediated. This is a cell, this is a macrophage, an NK cell, a neutrophil that's coming to kill, or through your complement-dependent cytotoxicity. So this is, again, your complement system being activated to kill it. So you can see that ADCC and CDC, these ones, they're mostly kind of, let's say, pushed by your FC. The FC is the one that is doing this. But the blocking and the signaling is all mediated through the Fab. So we can divide, literally, the kind of mechanism of actions through Fab mediated and FC mediated. So the FC mediated death, as we know them, is really by activation of your complement system or literally by your induction of different types of immune cells, be it macrophage, natural killer cells, etc. I'll give you a very good example for them that we use for B-cell malignancies. So B-cell malignancies is the fifth most frequent cancer in Europe. If you look at all lymphoid neoplasms, so all lymphomas, 95% of them originate from B cells. So generally, it's an overwhelming majority. So what happens with B cells? The B cells basically express unique targets like CD20 and CD19. These are targets that are only found in B cells. They're not found anywhere else in your body. This is a gold mine because you want, in your therapy, you want to make sure that it's literally targeting only your tumor cells. Or let's say specifically that to, let's say, reduce the number of side effects. So what you can do, so let's imagine these are your B cells. The red triangle is the CD20. You create an antibody. And what happens is simply your complement system is going to come and get activated. And literally your immune cells coming from macrophages, monocytes, neutrophils, NK cells, they're going to come and literally kill off your target cells. So you're, in this case, your malignant B cells. But how are, again, these antibodies able to recognize, or let's say communicate with your immune cells to come and kill these target cells? As we know, the Fc receptors. These are the ones that are really kind of mediating this whole thing over here. And I'm going to be coming back specifically back to this in a bit, specifically to this inhibitory receptors. The Fab-mediated death, you can have two different types. You can have the agnostic effect, and then you can have the antagonistic effect. So the agnostic effect is literally when the binding of an antibody is literally causing an activation that's leading to basically death of the cancer cell. And antagonistic is where the blocking is blocking something and then basically causing the death of the tumor cell. So when it comes to agnostic, these are basically specifically your CD40 antibodies. What CD40 antibodies do, they bind to dendritic cells. And what dendritic cells, what they love to do technically, is they love to take antigens from your tumor, present it to T cells, and T cells are going to come and kill it. So by binding, having an anti-CD40 antibody, you're activating dendritic cells because it's binding to CD40, and that's activating them. So now you have dendritic cells that are literally just much more activated and literally creating more T cells to kill tumor cells. But also the CD40 can actually can bind to CD40 on macrophages. And now macrophages are much more activated and can actually start to kill much more tumor cells. It can actually induce much more the let's say, phagocytosis of them. Now the antagonistic, that's usually the main type of way that basically antibodies kill, is literally by blocking. One thing that we know when it comes to cancer is that they require certain signaling capacities to keep surviving. Because what's the difference between a normal cell and a cancer cell? Well, it's purely coming from its ability to keep proliferating. So one thing that we tend to see with cancer cells is they express a lot of different types of growth receptors. These receptors that help them proliferate. An example of growth receptors are these HER receptors. There's HER1, HER2, HER3, HER4. These receptors, basically what they do is when they're activated, they can increase proliferation, invasiveness, angiogenesis, resistance to apoptosis, you name it. One thing that we see in breast cells, you have, let's say, this normal amount of HER2 receptors. These are basically around 5. Breast cancer cells, some of them, we call them HER2 positive. These basically upregulate the HER2 receptor. Suddenly, from going from 5, you have, let's say, 10. You're doubling it because now this HER2 positive breast cancer cell has so much signaling for it to keep on proliferating and resist apoptosis. So what you can do is now you can create an antibody that's going to bind to HER2. And that is really going to stop it basically from doing all the signaling. And now what happens is now you stop the signaling. Now this cell doesn't have any more the signaling to resist apoptosis, to proliferate. It's going to die. So by blocking the signaling there, you're able to kill it, to basically block quite a lot you can actually induce the killing of it. This is a very, very old, one of the first clinical trials of basically an antibody against HER2, which is called trastuzumab. So trastuzumab basically binds to HER2. So this very, let's say, thick line is trastuzumab plus chemotherapy. And over here, basically this, let's say, very wiggly line that is more gray, different kind of shadow, is chemotherapy. You see basically that people receiving trastuzumab plus chemotherapy actually had a better probability of survival compared to people only receiving chemotherapy. You have an increase of 25% of probability of survival. Despite that, nowadays this is quite low. Back in the day, I took this literally picture from my master's in Kent. My professor was actually in the in the conference in ASCO, the American Society of Clinical Cancer conference, where they were showing this data for the first time ever. And he was telling us that people were crying of joy because for the first time that they ever managed to see this increase of 25%, they started to feel that, hey, we're not able to tackle cancer. So this was really, let's say, the very early pioneering work of how antibodies can be useful in cancer. Then now comes checkpoint inhibitor therapy. So now this, I would say, I love the transition from this because this is, let's say, the old kind of state. This is the new stage. These are checkpoint inhibitors. These are, if you guys don't know, this is James Allison and this is Tasuku Honyo. These were the ones that received the Nobel Prize in Medicine in 2018. And they're the ones that basically discovered these new type of antibodies that we call checkpoint inhibitors. But one quick fact, this is Tasuku Honyo's actually presentation that he gave in the basically in Stockholm during when they gave him the prize. One thing that really stuck out to me is that, of course, when we were being taught on how to create an antibody, first thing they always told you, never use yellow fonts and never use Comic Sans. And I remember when I was seeing this, I was like, but this guy just used both two things that they did tell you not to do. But at that point, I realized like this guy just won a Nobel Prize, so he couldn't care less about this point. So to me, it was just like a funny thing to see. But before I get into why they were actually given this Nobel Prize, I want to give you the axis that Tasuku and James Allison were working on, which was basically checkpoints. So one thing that we know, our immune system has to be in a key balance. Why? Well, purely because if you stimulate your immune system too much, you have autoimmune diseases. Quite well known. But other than autoimmune disease, you get autoinflammatory as well. If you suppress it too much, you get cancer. We've seen with humans that are basically, that have, let's say, lack certain immune cells, or even mice that if you remove a certain immune cell, they tend to develop cancer much more much more frequently and aggressively, actually. So our immune system has to have this delicate balance. In a sense, it cannot get too stimulated and it cannot get too repressed. Well, how do you manage to get this fine balance? Communication. That's how you're able to do that. And this communication is all based on two main type of cells. Your antigen-presenting cells, like dendritic cells. These are the ones that are literally taking antigens from your microorganisms, from your cancer cells, and they're presenting it to T cells. T cells are literally your soldiers. These are the small little things that go around your body and start killing. So it's extremely important that your antigen-presenting cells and T cells communicate. And they communicate through all these different types of immune checkpoints. So for example, let's take an example basically over here. So let's imagine now your antigen-presenting cell now is found. Let's imagine you're infected with influenza. Your APC, your antigen-presenting cells, they take up influenza, and it takes a piece of this influenza, this epitope, and now it's presenting to a T cell. It's going to present to a T cell, and it's going to communicate with it through its B7-RP1 basically protein, and it's going to bind to the ICOS in the T cell, and it's going to literally, this communication is going to tell the T cells like, okay, I need you now to start getting activated and start to basically recognize this piece of influenza that I just took. So this is how basically this APC is able to tell the T cell like, hey, we need you to start getting activated because we are under fire. We are under an infection. But let's imagine now that the T cells did their job. They basically have removed all of your influenza infections. Awesome. Well, what's going to happen now is that these T cells need to go down. They need to stop, because if these T cells keep killing and they keep getting activated, hello, autoimmunity. So your APC is going to come and it's going to communicate with them specifically through its PDL1 or PDL2, and it's going to bind to it and it's going to be like, hey, T cell, stop. We need you to go literally down. And what's going to happen is this negative, basically, communication between them is going to make the T cell go into anergy, which basically means a state where it does not do anything, or into apoptosis. So basically reducing it. So this is how you maintain it. So this is exactly how it happens. Let's imagine technically over here, these green little boblets are literally, let's say, your antigen-presenting cells. These, let's say, purple things are your T cells. You're infected. Your boblets, these APCs are now taking a piece of whatever you're infected with, and it's presenting it. So this is basically, this red thing is the whatever microorganism you're being infected with. It presents it to your T cell. And again, this communication B7, B, and CD28, if you look at this, basically, it's positive. So it's telling your T cells start to expand. Great, it expands. And now you're basically suddenly, so this basically, this dotted line represents technically your T cells. Now suddenly your T cells here at its peak, they've managed to remove your microorganism that you've been infected with. It's gone, perfect. They need to start dying, because if it stays here, autoimmunity. So it comes back literally your T cells. Now your basically T cells start to express something called CTLA4. CTLA4, if you know, it's negative. So this is a communication that now they have together, and they go to anergy. This anergy is a state that they do nothing, or they go into apoptosis. So you're removing down. So this is how you regulate it. So how does this relate to cancer? So this is basically a very famous review, which I'm quite sure many of you guys have read. It's called The Hallmarks of Cancer. This is basically one of the most cited ever reviews in cancer. And it technically tells you what cancer needs to do to survive. And in 2000, these were the hallmarks. Now, if you basically jump forward to 2011, so the same authors, Douglas and Weinberg, which rewrote it again, they basically now added basically avoiding immune destruction. It was one of them they added, because they started to see that our immune system has an impeccable job at killing literally our cancer cells, to the point that in our body, we have something like 1,000 cancer cells that are growing on a daily basis, by the way. But it's actually our immune system that is able to stop them. So if a cancer cell wants to be successful and wants to actually grow into a proper tumor, it needs to avoid immune destruction. How are they avoiding immune destruction? They're literally using the checkpoints. So what they're doing, some cancers are making T cells express so much CTLA4 that now when you have your antigen presenting cell coming in to make your T cell better, so imagine this is your tumor peptide, it's trying to tell your T cell like, hey, there's a cancer. This is the antigen that you need to recognize and go and kill it. But the T cell, sadly, it has a lot of CTLA4 because the cancer made it express a lot of CTLA4. And what happens is that now the T cells are not being created. And that's a huge issue. But what you can also have is the tumor cell can also be very smart and sneaky. They can produce a lot of PDL1 and PDL2. Because now imagine the T cells are now ready to kill. They have a massive, let's say, army of them. They're ready to come and kill. But the tumor cell has a lot of PDL1. This binds to PD1 on your T cell, and this gives a negative. This is something that the APC has, but now the tumor has it, and now it's actually overexpressing it to make sure that T cell doesn't come and kill it, because this makes the T cell go into anergy or into basically apoptosis. So Tasuko worked mostly on this axis. He started to see PDL1 and PD1 interactions within the tumor cell and a T cell. So he was looking at it at a tumor level. James Allison, on the other hand, was looking at it, this occurs in your lymph nodes. So he was looking at it a bit more up further. What's happening over here? So they both had this brilliant idea. They're like, okay, what happens if we actually block it? Let's imagine if we block, let's imagine this was CTLA4. If we block the CTLA4, James actually thought that, hey, if I block this, I'm going to create a massive army of T cells that are going to be ready to go and kill your tumor. That was basically James Allison's way of thinking. Tasuku Honyo thought about it in a different manner. He said, like, hey, it's the tumor cell expressing this PD-L1. If I block this, I'm allowing the T cells to come and kill it. So they were working in two different axes, but very similar consequence, creating your allowing your T cells to come and kill. So in this case here, you're creating an army to go kill it. Here, you're basically allowing your T cells to kill the tumor cell. So this is basically a clinical trial with metastatic melanoma. So a bit of background with melanoma. Melanoma has a 99.9% chance of surviving. It's very easy. It's simply a very easy surgical removal of your melanoma lesion. But if it hits metastatic, your chance of from 99.9% of living drops down to 0.01. It's very deadly. Metastatic melanoma is literally almost a death sentence. So here you have basically ipilimumab. Ipilimumab basically is a CTLA4 antibody. So this is what you have. This is the progression-free survival. This is the overall survival. Suddenly you have a 34% from a disease that was literally 0.1 to 34. That was a huge increase. This is now nivolumab. Nivolumab technically is your PD1, yes, your PD-1 antibody. So this is the one that's basically preventing tumor cells from basically using their PD-L1. And you have even a higher. Now half of the people are basically surviving. So you see quite a nice increase. But then people started to think like, okay, but what happens if we combine them together? What happens if we have now ipilimumab, so CTLA4? You have a huge army of T cells. So this army of T cells, they're going to go to your tumor cell and try to kill it. But the tumor cells have PD-L1. They're going to be able to stop this army. But let's also block it. So rather than also having a huge army, let's allow them all to kill. And that's what they did. They actually had this nivolumab plus ipilimumab. And that also further increased even more their survival. But the issue, these now drugs, you're messing up with your immune balance. What happens? Sure, this is basically pre-treatment. So these arrows are the tumors. You have now suddenly basically no tumors anymore. So beautifully. But look what's happening over here. Dermatitis, colitis, hepatitis. Literally, these patients have so much inflammation all over their body because you're messing up the immune system. Now T cells are literally on overdrive. So that's a huge issue. So having actually nivolumab plus ipilimumab, even though you have a greater chance of living, your secondary effects, your side effects are so big that they can actually kill you. They're not that well tolerated. So it's not a lot of people get these combinations. And if they do, they basically have certain, let's say, doses and certain, let's say, timings of it to make sure that it's safe. So now if you look at basically the checkpoint inhibitors being accepted, this is I think from 2018. I couldn't find really one that was, let's say, updated, but this is just to show you where they are present. They're everywhere. Literally, I think almost every single type of tumor has it. Not all, because I know pancreatic and colorectal cancer do not have it, but the majority of cancers actually have checkpoint inhibitor therapy actually accepted for them. And not just basically just accepted, they're actually first line, meaning that this is the first therapy that the clinician is obliged to use. This is how good they are. And this is why they won the Nobel Prize. Again, showing you how we went from the old class of trastuzumab to the new class, which is this checkpoints. That basically now a lot of our basically work is based on. And now, of course, there are other different checkpoints. They're not just, there's basically PDL1, PD1, or CTLA4. There's TIM3, there's VISTA, there's LAC3. These are all inhibitory receptors that you can basically kind of inhibit. There's also other activating receptors. You can actually make the T cell more activated, but this can be very dangerous because if you activate them too much, you can actually cause them to go override. Yes. So another form of antibodies that we've been using a lot in the clinic are antibody drug conjugates. So this is now a hype. So if you look at now, basically what pharmaceutical companies are looking for, it's antibody drug conjugates. So here is a very interesting kind of way of looking at antibodies. We're looking at antibodies as now vehicles, in a sense that we don't care for the antibody, we care for it because it's basically purely it's very specific. So what we can do is we can attach to this antibody chemotherapy. We can add cytotoxic drugs that are basically going straight to your tumor. So rather than adding something systemic that is very, let's say, toxic, we can actually attach it to an antibody and make sure it reaches the perfect place. So think about it as a Trojan horse. You're literally deceiving your cancer cell to take it up and basically deliver your cytotoxic drug. So let's use the most famous one, trastuzumab emtansine. So what they did, they took trastuzumab, the same antibody that binds to HER2, but here they had a linker, this MCC linker that basically linked the antibody to this DM1. This DM1 is basically a chemotherapy that basically what it does, it stops microtubule formation, so hence it basically makes cells go into apoptosis. So what happens is that when this basically trastuzumab binds, it's taken up and is then basically cut. So this linker is cut and allows now your DM1s to be released specifically to your tumor cell. Actually, the most difficult part when it comes to antibody drug conjugates is the linker. Finding a linker that's able to actually bind, first of all, to trastuzumab and DM1 is hard, but what is much more harder is a linker that is able to be cut clean over here and here, specifically to DM1, because let's imagine it cuts over here. This DM1 might not work because now you're adding an extra basically functional group. So finding a linker that is able to be cut precisely very well once in the lysozyme is not the easiest task. It's actually the most difficult one. But this is just basically an example on how good this trastuzumab emtansine is. They used again in breast cancer. The blue line is trastuzumab emtansine, and the red line is the physician's choice, meaning that the physician could choose whatever drug they wanted. And they saw that, of course, people that had trastuzumab emtansine had literally a much more higher overall survival compared to the physician's choice. And now there's so many different types of antibody drug conjugates in the clinic. For the first time ever, triple negative breast cancer, which is a form of breast cancer that is very aggressive, basically now accepted a antibody drug conjugate. Like this is months ago into as a way to treat it. So now before getting into this, I'm going to give you a 5-minute break. So we'll come back at 11:30. So just to give you guys a small little break, and then we're going to go into FC engineering. All right, guys, let's get back. Okay, so now comes my favorite part, which is FC engineering. So as we really did speak at the beginning of this lecture, we spoke a lot about how the FC per se can really be changed, and how the FC is so important when it comes to actually the effector functions, and how having an IgA is different to having an IgG, to an IgE or M. Well, we can sometimes use that to our actually advantage. So let's go back into the basically the FC receptors, and specifically IgG. And why specifically I'm going to IgG right now is because if you look at all the antibodies in the clinic, all of them right now currently are of the IgG isotype. So basically knowing that, it's gonna help you quite a lot. So basically the IgG antibody binds to Fc gamma receptors, and in humans there's basically 6 of them. There's this Fc receptor 1, 2A, 2B, 2C, 3A, and 3B. And basically here it tells you the function. I love this basically here because, for example, here they say 3B is activating, even though that it's not. It's actually not activating because it doesn't have any signaling capacity. So this is actually seen as inhibitory. But what does that technically mean? What it technically means is that when an IgG antibody binds to basically let's imagine FC2A, it's going to activate. It's going to make the immune cell start to kill. But if it binds to 2B or 3B, it's going to inhibit, because they have actually, specifically 2B has this item with this inhibitory motif that inhibits your immune cell from doing anything. How can this really, let's say, be a huge issue? Well, purely because if you have immune cells that have a lot of inhibitory receptors, for example, neutrophils, when neutrophils have a lot of these items, a lot of these Fc gamma receptor 2Bs, they're not really going to be killing, because the IgG is mostly going to bind to the 2B, and it's going to make the neutrophil not kill. So people started to realize, okay, how can we make it better? And they started to look at rituximab. They're like, okay, rituximab is an IgG antibody. How can we make it better? They started to realize, how about we actually make the Fc more, let's say, kind of selective towards the activating Fc receptors and not bind too much to the inhibitory ones. So what they did, which is something very smart, is they defucosylated. So antibodies in general, specifically their Fc, are heavily basically glycosylated. They have a lot of basically glycans, which are basically in this kind of form. So what they saw is that if they removed a fucose from this IgG antibody, this removing of a fucose, for some reason, made this antibody bind more to activating Fc receptors than inhibitory ones. So this actually was able to actually only kind of enhance much more the activation of Fc receptors, because it's not binding to the inhibitory ones anymore. And they called this antibody obinutuzumab. So obinutuzumab technically had a much more higher ADCC. So it was actually able to induce much more killing through the immune cells. And this actually worked. So this is rituximab. So this is now basically Gazyva, which is basically obinutuzumab. So the difference between these two is basically this defocusylation. This one is able to activate your immune cells to kill more, and it worked literally 30% better. It's crazy how good it actually worked by just engineering a bit of that Fc to make it much more active. And now, because of that, it really pushed a huge field to start looking much more into different mutations. So now this is here a list of all different mutations that can enhance basically the, let's say, affinity to different types of receptors. For example, much more towards the activating ones or more to the inhibitory ones. Let's imagine that you actually want antibodies that you don't want them to actually bind or activate any immune cell. All you want to now create a mutation that prevents them from binding to Fc receptors, for example, and they're found. So different things that you can do technically. But one other thing than just adding mutations, one thing that we can also do is change the whole Fc. And that's basically what I was doing in my master's. So again, let's go back to this example over here with B-cell malignancies. So we know with IgG antibody therapy, they kill through complement, and they kill through basically your antibody-dependent cell-mediated cytotoxicity. So your cell-mediated killing. as we know, as I just spoke, we have six Fc receptors, Fc gamma receptors. They can be put into two groups, activating and inhibitory. And if we put them basically there where they're expressed, macrophages, monocytes, and neutrophils, they express a lot of inhibitory receptors, and specifically neutrophils. Because basically what happens is that the IgG, when it's trying to activate the neutrophil, it's not able to do so because there's so many inhibitory Fc gamma receptors that because of them, the neutrophils are not activated. And monocytes as well, and monocytes, macrophage and monocytes. It's usually NK cells. NK cells are usually the ones that are being activated during IgG antibody therapy, which is great, but in a sense, it can be exhausting for the NK cell to do all the killing. And that's what happens. In cancer, it's a chronic disease. NK cells, after 4 or 6 hours of killing, they get exhausted. And it takes them about 24 to 48 hours for them to basically gain back the ability to kill. In those 24 to 48 hours, you just let your tumor cells go unchecked again and replicate. So it's a huge issue. So what my supervisor doing my master's was thinking, she was thinking like, hey, how about we use an IgA antibody therapy? Why? IgA binds to a different Fc receptor, the Fc alpha, and there's only one of them in humans that's just basically called CD89. And it's activating. It's found in your neutrophils, in your monocytes, and your macrophages. So now you have sorry, one thing that I also forgot to say, NK cells do not have Fc alpha. So you're kind of eliminating NKs. But at least you have neutrophils, you have your monocytes, and you have your macrophages now, kind of making them come and kill your tumor cells. So you're having 3 different effector populations rather than just one. And these are just experiments. These are actually experiments from my own master thesis that I actually did. So what I've done here is I've taken target cells. So these are basically malignant B cells, and I added effector cells. And I basically either chose NK cells or neutrophils. What I did also with your target cells, I made them basically, I radio labeled them. So I added chromium. So these basically target cells had a lot of chromium. So when I added effector cells and my antibodies, what I would expect is that because of the antibody, your effector cells are killing your target cells and they're releasing chromium. The amount of chromium released to your supernatant is technically proportional to the amount of killing. So by counting how much chromium there is in the supernatant, you can actually quantify how much target cells were killed. And that's basically the experiments I did. So here I created 3 antibodies, UMAP 7, 9, and 10. These were all against CD20 and were basically of the IgG1 isotype. So here, basically what I did is I took your B-cell lymphoma and I added neutrophils. So PMNs are neutrophils. So with IgG antibodies, so this is the antibody concentration, even at very high of like almost 20 micrograms per ml, this is quite a high concentration for antibodies, you don't get anything. Very little killing. Like what, 10%? No, I took the same antibodies, UMAP 7, 9, and 10. Only thing I changed was just the FC. So rather than IgG1, it's IgGA1. Now, from this less than, let's say, 10%, now it's around 60. Make it an IgA2, I get 80%. So IgA2 is just a different subtype of IgAs. You start to get much more killing by just simply changing the antibody isotype. So this is a new thing that actually my supervisor now is pursuing in the clinic. She, rather than using for B-cell lymphoma, she now is pursuing this for colon cancer. I think she's in phase 1 clinical trials with this. Another very interesting antibody isotype that's been used also in the clinic are IgE. So IgE, as we know, actually induces allergies. And one thing that we started to see is that people that have actually a lot of allergies, they tend to see some sort of response to their tumor. Because what happens is that because their mast cells and basal cells are heavily activated, they release a lot of chemicals, like specifically leukotrienes and histamines and all these different types of things that are very actually anti-cancerous. They can actually have anti-tumor properties. So they started to see that, hey, can we use an IgE antibody to make this more, let's say, allergy, more focused to the cancer and may actually kill it even better? So they created an IgE antibody. So they call this MOV-18. MOV-18 basically binds, if not mistaken, to an EGFR receptor. I think it's written here. No, but I think it was basically binding to an EGFR receptor in colon cancer. So the IgE antibody is able to actually induce a very high, let's say, immune response, or more, let's say, allergic response in your tumor, specifically in your tumor, to actually allow the killing of your tumor cells much better. So they did a phase 1 clinical trial. So of course, the biggest issue, or let's say safety concern, was that if I had this IgE antibody, will I get such a huge this anaphylactic shock, this kind of high excessive allergy response? So they did basically this test, and they call this the skin test. So this is a negative control. This is basically giving you MOV-18, and this is basically a positive control, something that you know that you're going to get an allergy to. So when you do the skin test, you develop these kind of, let's say, kind of irritations, skin irritations. So they saw that people that had MOV-18, the antibody, did not develop any allergies in the skin or anything like that. So hence no anaphylactic shocks. So it was quite, let's say, safe. But other than safe, it was quite successful. They actually saw a lot of people actually having a lot of their colon cancer really get reduced. And basically, this is basically one patient basically almost got cured by just changing, again, the Fc isotype. So one thing that I basically, when I came to do my PhD at Vince's lab, Vince has this very weird but very cool kind of philosophy. He likes, in a way, of course, to give you a project, but he also likes for you to come up with a project. This might be intimidating, but I loved it personally because I felt ready to make a new, let's say, create a project out of my own thoughts. And I was very into antibodies during that time when I did my PhD. And of course, I was, very into IgA antibodies, as you have just kind of have shown you. Why? And I realized that, okay, IgA antibodies are very good for activating macrophages, monocytes, and neutrophils, but they do not activate NK cells, which is such a pity. NK cells are extremely powerful immune cells to kill cancer. And I always thought to myself, that is such a waste. So what did I think is like, okay, what can I do to make this better? So I started to think, why don't I create my own FC? So what did I do? I took parts of an IgA that bind to the Fc alpha and parts of the IgG1 that bind to the Fc alpha, Fc gamma, and I put it together. So now I have a new basically Fc that is half IgA and half IgG. And basically I put here a PD-1 ecto domain. So this basically now binds to PDL1. So now I created basically an antibody against PDL1, and where the Fc is half IgG and IgA. Because now I was basically being able to take the killing of your macrophages, your neutrophils, and also basically as well your NK cells and your complement. So I had this antibody that's able to be able to activate almost every single type of immune cell. So I'll just quickly go here. So this is basically I call this AdCap technically, this antibody. So this is basically here at different concentrations. This is with B16F10. This is technically a murine melanoma. So we have basically unarmed, so basically nothing, and then this is AdCap. So what I saw with AdCap is that at this concentration of 100, we managed to actually activate your complement system. We managed to activate your NK cells, and we actually also managed to activate your neutrophils and your macrophage and monocytes. So I was able to do all the different things that an IgG and an IgA antibody can do, but all in one. But then the question is, can it basically actually work all together? So I repeated this experiments, and where I added NK cells, neutrophils, basically here. So this is AdCap, and here you have the PDL1, but with an IgG1 Fc and an IgA, and we see that AdCap actually does much better than them. This is 41. This is basically a triple negative breast cancer. It also does better than the others. This is lung cancer, basically again. Here to the NKs and neutrophils, I added complement, and I get to see even a higher killing. So yes, the antibody per se itself can simultaneously activate neutrophils, NK cells, and your complement, and can lead to more killing. Okay, this is in vitro. This is work actually in vivo. So I got mice. So I gave them basically colon cancer, so CT26. And basically, this is the kind of dosing schedule. So mice given mock were shown in blue. So these are basically just PBS. Here I gave two different types of cancer therapies that are given to colon cancer. This adeno 5/3, this is oncolytic viruses, and this is the checkpoint therapy that is actually in the clinic, but this is the mouse version of it, shown in purple, and then ATCAB. So the golden standard that's used in the clinic is this basically purple one. And we saw that ATCAB actually did much better. And not just only was it basically better in tumor size, it actually in overall survival, you increased the overall survival from 40% to 80. So this is a 50% increase in overall survival. I went on to test this even in a more, let's say, kind of human, basically kind of version. So what I did is I basically took pieces of tumors from patients and I grew them in these organoids. We call these patient-derived organoids. So these were from renal cell carcinoma, so kidney cancer. These are coming from 4 different patients. If you grow them basically at 2D, this is what you get. But if you grow them in a 3D matrix, you have this beautiful, nice spheres that we call patient-derived organoids. These are just some basically some nice immunofluorescence staining that we did to show that, yes, these actually balls of cells are actually coming from renal cell carcinoma. And again, we did here the killing. So with PBMCs, so these are NK cells, with neutrophils, or with both of them together. And again, the same groups, ATCAB, then atezolizumab. This is basically the current one in the PD-L1 in the clinic. And this is with adjuvant PD-L1. ATCAB is doing better when you put both these kind of cells. So again, this really made me think like, okay, this could actually work. This is actually something that I'm actually pursuing. I actually managed to get a business fill-in grant last year. And hopefully by the end of this year, we're trying to spin out to go into phase 1 clinical trials in ATCAB. And we want to go into try to treat colon cancer, but also pancreatic cancer with this therapy. So I'm going to remove this. One last thing I want to quickly talk about are basically beyond antibodies, we can also start using these small little light chains. So we can use these fabs. So remember, these fabs, these are the variable regions coming from the, the heavy chain and the light chain. So these are the parts that are literally binding to whatever. Because sometimes what you want is you just want things to bind. You don't care about the FC. Basically, you have many different forms that you can basically form. I'm not going to really talk a lot about them. But one thing I want to talk about are bites, which are consisting of basically fabs. So what basically bites are, they're called bispecific T-cell engagers. They're literally 2 fabs that are connected to each other. One fab literally binds to your T-cell, and another fab binds to your tumor cell. And what these fabs do is they bring your T-cell and your tumor cell so close to each other to the point that they're kind of forcing them to kiss each other. And they call this the kiss of death. Because when a T-cell and a tumor cell get so close with each other, the T-cell gets activated and it kills it. The exact mechanism of how this happens, we still do not know. But these bites are becoming a new, let's say, type of therapy. So again, it's a very simple concept of where you literally take the Fab region of this antibody. So you literally are taking just the region responsible for the binding from that, and this one you take it from CD3, which is binding to your T cell, and you take the other one that's binding to your tumor cell, and you connect them together. So this is your bite. There's literally 2 fabs that are joined together. One part of the fab is binding to your T cell, and the other one is binding to your tumor cell, and it's literally making your T cell come so close to contact to your tumor cell that it's killing it. And one very nice example of this is Blincyto. Blincyto is actually FDA approved for non-Hodgkin's lymphoma, if I'm not mistaken. It basically binds to CD3 and CD19 on your malignant B cells and makes them basically kiss and kill each other. This is just to show you how good it is. This is chemotherapy, and this is basically coming from blinatumomab you see a very big, basically, increase in overall survival, but also in events-free survival. And now many people are creating so many different types of bispecifics, basically either binding to CD3 to your T cells, and then basically the other parts to different parts of the tumor. This is for breast for HER2, CD20 for multiple myeloma, EpCAM for ascites, NG2 and melanoma, and on and on. But other than basically CD3, people are using, for example, CD64. CD64 is on NK cells and macrophages. So you're bringing other cells. So these bispecifics, they are quite, in a way, simple. One part has to bind to any immune cell that you want, and the other part binds to a target in your tumor cell. A very cool thing that is coming up right now are tri-specific antibodies. These are coming from Sanofi. Now they're basically having this antibody that is able to bind from one basically arm, this target in multiple myeloma, which is CD38. And another, these basically, they managed to create this click chemistry, and where you have these two different Fab arms over here. One is binding to CD3 and the other one is binding to CD28. Both are found on a T cell, but binding of both of them makes the T cell much more active. So it's able to kill myeloma cells much more compared if you just bind to CD3 or CD28. And these are now going, I think, if I'm not mistaken, into phase 1 clinical trials. So guys, thank you so much for listening to me. I hope that you guys managed to enjoy and managed to actually understand. Open for any questions, please go for it. Any sort of curiosity, anything that you might have? Well, I think that means that it was quite clear. But guys, if you basically have any questions or any of that sort, please feel free to email me. And with that, I wish everyone a very nice weekend. Thank you so much for joining in.
Thank you.
Thank you.
Thank you.
Thank you, guys.